Welcome to your North County Fire Authority Trauma Field Protocol and Procedure Annual Review. Today's focus is going to be on trauma treatment protocols and field procedures such as tourniquet application, wound packing, hemostatic gauze, thoracic trauma, crush syndrome, chest seals, needle decompression, spinal injury assessment, and spinal motion restriction. Here's the trauma triage chart. This essentially is the flow chart when you have a trauma activation. As you can see, there's 1, 2, and 3. Each one of those headlines gives you patient presentation or symptoms that qualify them for a trauma activation. If the patient has any of those, they are to go straight to a trauma center with early hospital notification. If not, then they could be transported to the nearest hospital of patient choice. Continue with the trauma triage protocol. There's flowchart section 4 that's going to give you some risk factor advisories. You're also going to have your list of pearls as well. Key points of the trauma triage is obviously to identify if early trauma activation notification is necessary. If so, your scene time goal is no more than 10 minutes. Vital signs level of consciousness that require immediate trauma center notification and transport will be a GCS of less than or equal to 13, an adult systolic blood pressure of less than 90, a respiratory rate of less than 10 or greater than 29 or needs airway support, a child systolic pressure of less than 60, an infant respiratory rate of less than 20. Obviously, we want to do a thorough assessment, a primary and a secondary. Ensure that we strip and flip the patient, that we do not miss anything. We always want to perform our DCAT BTLS, checking for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Our receiving trauma facilities are going to be Zuckerberg, SF General, Stanford, and Eden Medical Center. Obviously, for the North, SF General is going to be our main trauma facility. If base contact is indicated in a trauma incident, make sure that you're making your base contact through our trauma facility, which again is SF General. Some additional key points are mechanisms that qualify as a trauma activation. Adult falls greater than 10 feet, a pediatric fall also greater than 10 feet or 2 times the height of the child, an auto accident or a death or ejection in the same vehicle, an extrication time of greater than 20 minutes, an impact speed of greater than 40 miles per hour, a rollover with an unrestrained occupant, intrusion on patient side or roof of greater than 12 inches or greater than 18 inches at any site, any auto versus incident that results in the separation, thrown from, or ran over. And some additional risk factors to keep in mind is pregnancy over 20 weeks, a communication barrier, age 55 or older, patient taking anticoagulants or has a known bleeding disorder, CNS changes, or time-sensitive injuries. Here's the extremity trauma flow chart. It starts off with if the injury is a crush injury or not. If not, it's going to advise you to control hemorrhage by applying a tourniquet. We will also be discussing some other methods such as wound packing, direct pressure, etc. It also gives you fluid resuscitation as well. And again, some pearls in addition to the flow chart. The key takeaways with extremity trauma is we want to control hemorrhage early by applying a tourniquet, wound packing, hemostatic gauze, direct pressure, etc. If the systolic blood pressure is less than 80 in adults, you can administer a normal saline bolus of 500 milliliters, which can be repeated if the blood pressure remains less than 80 for a max of 1 liter. If poor perfusion or shock is identified in pediatric patients, you can administer a normal saline bolus as referred to the pediatric tape for dosing, and you can repeat doses as it advises as well. In the absence of head trauma, hypotension, poor perfusion, or an altered mental status, consider fentanyl for pain control. As mentioned before, an excellent tool that we have is the tourniquet to stop hemorrhaging. I have some instructions up here of our CAT tourniquet instructional use. Obviously, we want to apply the first tourniquet proximal to the wound. We're constantly going to be reassessing and tightening if needed, and apply a second tourniquet proximal to the first if bleeding can still not be controlled. We always want to note the time of the tourniquet application. Wound packing indications are going to be patients with severe wounds in critical vascular areas that not amenable to tourniquet use or pressure dressing alone. Femoral triangle and anterior triangle of the neck, severe wounds of the limbs, shoulders, and hips. Contraindications are going to be wounds of the abdomen, chest, or open skull fractures. Your procedure for wound packing is expose the wound and identify the bleeding. Open clothing around the wound, remove excess pooled blood from the wound while preserving any clots already formed in the wound. Locate the source of the most bleeding. Pack the wound completely. You want to pack gauze tightly into the wound and directly into the source of bleeding. More than one gauze may be needed. Use one gloved hand to feed gauze and the other to maintain pressure and hold the gauze in place. Use gloved fingers to maintain pressure and hold gauze. Proper technique will allow for continuous pressure. Be cautious of sharp fractures, edges, and foreign bodies when packing wounds. Apply and hold direct, firm pressure. Reassess bleeding while holding continuous direct, firm pressure. Apply pressure dressing to provide ongoing pressure and secure the wound packing in place. Transport and monitor. Do not remove the bandage or gauze. Notify receiving hospital staff that wound is packed with hemostatic gauze located of wound and time of wound packing. Hemostatic gauze is to be in combination with direct pressure. You can use on wounds where direct pressure or tourniquet has failed. You want to hold direct pressure over hemostatic gauze for at least 20 minutes. After, apply a pressure dressing over the hemostatic dressing. Pressure dressings and bandages should not have a tourniquet effect. Dressings can be left on the wound site for up to 24 hours. Crush syndrome is caused by muscle crush injury or cell death. It may develop in as little as an hour if a large area is involved, but typically develops within 4 hours. Hypovolemia and hyperkalemia may occur, especially in extended entrapments. A good motto to identify a potential crush injury is larger than a hand or longer than an hour. The treatment will be prior to release from entanglement, administer a continuous nebulization of albuterol. For suspected hyperkalemia, which we can identify for peak T waves, a QRS greater than 0.12 seconds, or loss of P waves, you're going to administer the albuterol again, 10 milligrams nebulized continuously, calcium chloride, 1 gram IVIO over 1 minute, and sodium bicarb, 1 milliequivalent a kilogram IVIO. We always want to remember to never administer sodium bicarb and calcium chloride in the same IV due to crystallization. For thoracic trauma, some signs and symptoms that we're going to be looking for is dystonia, tachypnea, anxiety, diminished breath sounds, hypotension, tachycardia, narrowing pulse pressure, tracheal deviation, and late signs of shock. Common thoracic trauma injury can be a tension pneumothorax, which is where air flows into the pleural space during inspiration, but not out. Air accumulates in the pleural space under pressure, compressing the lungs and decreasing venous return to the heart. Signs and symptoms are going to be chest pain, increasing hypoxia, respiratory distress, trachea deviation, and hypotension. This will be an indication for a chest seal. Russell chest seals are what we will be using in our trauma kits. For application, you want to check the patient for penetrating trauma to the thorax. Upon finding a wound, immediately place your gloved hand over it. Open the package and remove the seals. Do not remove the plastic backing to the seals. Take gauze and wipe away any blood, sweat, debris from the wound area. Only remove your hand covering the wound to clean, then place it back. Place the chest seal next to the wound. Slowly remove the plastic backing while rolling the sticky side over the wound. The seal should be centered over the wound. Verify the seal is sticking and that no air is heard passing through the seal during inhalation. Repeat as necessary for additional wounds. Continuing with chest seals, if a tension pneumothorax develops, treat by removing the chest wall dressing. If that's not relieved by removing the dressing, then you may perform a needle decompression. Russell vented chest seals are preferred. Vented chest seals allow for release of accumulated air or blood. They also prevent re-entry of air through the open chest wound. If you come across non-vented chest seals, they adhere to the chest, they create a tight seal, do not allow air or blood to escape or re-enter. Here's your needle decompression procedure. Indications with patients who are in pre-arrest with absent or severely diminished breath sounds and have at least 2 of the following signs: altered mental status, hypotension, increased pulse and respirations, percussion on affected side, jugular vein distension, difficulty ventilating, or tracheal shift. In patients with penetrating trauma to the chest or upper back or a gunshot wound to the neck or torso who are in respiratory distress, a weak or absent radial pulse may indicate hypotension. Signs of tension pneumothorax listed above may also be present. Patients in traumatic arrest with address or abdominal trauma for whom resuscitation is indicated, these patients may require bilateral chest decompression, even in the absence of the signs above. Assessment should be confirmed by a second paramedic. Your procedures, you're going to administer high flow oxygen, identify and prep the site, the preferred site, locate the sternal angle of the Lewis, which corresponds to the second rib, move down to the fifth rib to identify fourth intercostal space in the mid-axillary line on the same side as the pneumothorax. The second site, we locate the second intercostal space in the mid-clavicular line on the same side of the pneumothorax. Prepare the site with alcohol and allow it to air dry. Insert a 10-gauge catheter into the skin over the fifth rib and direct it just over the top of the rib into the inner space. Advance the catheter through the pedal pleura until a pop is felt and air or blood exits under pressure through the catheter, then advance catheter only to chest wall. Remove the needle, leaving the plastic catheter in place. Secure the catheter hub to the chest wall with a flutter valve. Policy for head trauma, you're going to focus on signs and symptoms, evidence of trauma, pain, swelling, or bleeding, altered mental status, unconscious, respiratory distress or failure, vomiting or seizure. Obviously, with any head trauma patient, you want early transport. Again, trying to limit on-scene time to 10 minutes. We always want to control hemorrhaging early. If spinal motion restriction is indicated, you need to do so. Secure the airway. Ensure that you elevate the head 30 degrees unless contraindicated. There's also fluid administration as well. If patient's systolic blood pressure is less than 110. We also want to monitor for increased intracranial pressure, which can be identified through increased blood pressure, altered breathing, or a slow pulse. And then, as always, our pearls. Key takeaways for head trauma is you want to keep a close eye on blood pressure and vital signs. Again, if the systolic blood pressure in adults is less than 110, you want to administer normal saline bolus of 500 milliliters, which can again be repeated if the systolic blood pressure remains less than 110 to a max of 2 liters. If poor perfusion or shock is noted in peds, you will then go to the pediatric tape and administer normal saline boluses as indicated. Monitor for increased intracranial pressure. Again, if you're looking for increased blood pressure, altered breathing, slow pulse, headache, pupillary changes, and vomiting may also be signs. With head trauma patients, we want to be hypersensitive and avoid hyperventilation, and we want to maintain capnography of 35 or greater. Multi-system trauma, again, we are going to be focusing on early transport time. We're going to control hemorrhage by the tourniquet, wound packing, or hemostatic gauze. We would always want to monitor our airway, ensure that we secure that. Spinal motion restriction if indicated. Place splints and cold packs to stabilize fractures as necessary. Consider needle decompression. And for open wounds to the chest or abdomen, we need to apply an occlusive dressing. We also have fluid resuscitation as well for these patients. And again, our pearls. Key points with multi-system trauma is to monitor the blood pressure. Adult systolic blood pressure is less than 80. Again, we're going to administer normal saline bolus of 500 milliliters, which can be repeated if the blood pressure remains less than 80 to a max of 1 liter. And again, in poor perfusion or shock indicated peds, refer to the pediatric tape for dosing. With traumatic arrest, this is designated for the first responder or public safety officer who find injuries that are incompatible with life. So including one or more of the following conditions will be deemed as a do not begin resuscitation. That would be decapitation, incineration, rigor mortis, decomposition, apnea with destruction and or separation of the body from the heart, brain, liver, or lungs, a multi-casualty incident where triage principles prelude the initiation or continuation of resuscitation. If they still do not meet one of those factors, again, if they do not have a pulse, they are apneic, no other signs of life, including purposeful movement or pupillary response, asystole or PEA at a rate of less than 40, or physical signs of trauma or blood loss, then also you do not begin resuscitation. For all other patients that do not meet that criteria, and you can have them transported to the trauma center in less than 20 minutes, which we very well should be with San Francisco General, then we want to control hemorrhaging, begin continuous chest compressions, high flow oxygen via BVM, immediate transport, and if suspected thoracic trauma, bilateral pleural decompression. If it's shockable rhythm, defibrillate. Just to review the key points and really hammer them in, your obvious signs of death where you will not begin resuscitation. It's going to be decapitation, incineration, rigor mortis, decomposition, apnea with destruction or separation from the heart, brain, liver, or lungs, MCIs where triage principles prelude the initiation or continuation of resuscitation, pulseless, apneic, no other signs of life, including purposeful movement or physical signs of trauma or blood loss, asystole or PEA with the rate of less than 40. If the patient does not meet the criteria listed above, it can be transported to a trauma center in less than 20 minutes, apply a tourniquet for hemorrhage, begin CPR, and consider pleural decompression. For burns, we want to initiate what type of burn it is by identifying if it is a minor or a major burn. A minor burn is considered less than 20% of the total body surface area, partial or full thickness burn, and with no inhalation injury and a GCS score of greater than 13. A major burn is considered greater than or equal to 20% of the total body surface area, partial or full thickness burns, and burns with suspected inhalation injury or high voltage electrical burns. We can always identify the total body surface by using the rule of nines. Additionally, with the flow chart for each one of those burns, for both of them, we want to consider removing all rings, bracelet, and constricting items, applying clean dressings, maintaining airway, and getting an IV established and giving fluid resuscitation, and ensuring that we are transporting the patient to the appropriate facility. Burns are going to be another flow chart. It's going to divide it between a minor or a major burn, minor being less than 20% of the total body surface area, where a major burn is greater than or equal to 20% of the total body surface area, and typically has inhalation injury or involves a high voltage or electrical burn. Each category advises you to remove rings, bracelets, and other constricting items, applying clean dressings to the burn, injury, and your fluid resuscitation. We also have the rule of nines, so you can get your total body surface area percentage. Key points are going to be your minor and major burns. Again, your minor burns are less than 20% of the total body surface area. Partial full thickness burns with no inhalation injury and a GCS greater than 13. Remove rings, bracelets, and constricting items. Apply clean dressing. Consider an IV. Your fluid boluses are going to be for children that are the age of 5 years or younger, 125 milliliter bolus, 6 years old to 13 years old, the 250 milliliter fluid bolus, and older than or equal to 14 years of age, a 500 milliliter fluid bolus. And as always, we want to consider fentanyl for pain. Major burns are going to be greater than or equal to 20% of your total body surface area, partial full thickness burns, or burns with inhalation injury or high voltage electrical burns. When you remove the rings, bracelets, and constricting items, apply clean dressings, establish an IV or IO, considering large bore in each AC. We're going to be monitoring their capnography. We're going to be doing the same fluid resuscitation as mentioned above, and we're also going to consider fentanyl for pain. Our burn centers are St. Francis in San Francisco, Valley Med in San Jose, and UC Davis in Sacramento. Just a reminder, burns with trauma need to go to a trauma center. If it is a burn-only injury, then they will go to a burn center. Your spinal injury assessment is for suspicion of spinal or neurological injury. You're going to have the patient extend both wrists and touch each finger to his thumb. Have the patient flex each foot upward and down. Ensure the patient has gross sensation in all extremities, and you will note any deficits. Explain to the patient the actions that you're going to take when assessing the spine. Ask the patient to immediately report any pain verbally by answering questions with a verbal yes or no answer rather than shaking their head. With the patient's spine supported to limit movement, begin palpation at the base of the skull, at the midline of the spine. Palpate the vertebrae individually from the base of the skull to the bottom of the sacrum. On palpation of each vertebrae body, look for evidence of pain and ask the patient if they are experiencing pain. If evidence of pain along the spinal column is encountered, the patient should be immobilized. Your risk assessment is a history of high velocity blunt injury increases spinal injury risk. Axial load injury to the head, an example would be diving, increases spinal injury. Low velocity injuries such as falls from a standing position or lower velocity motor vehicle accidents have increased risk in patients 55 and older. Spinal motion restriction is determined by spinal injury assessment. If there's pain upon palpation of spine or if there's neurological deficits. The procedure is going to be explaining the procedure to the patient, assess and record extremity and neurostats and distal pulses, place the patient in appropriate size C collar while maintaining an inline stabilization of the cervical spine by a second provider. Methods used to achieve SMR that are allowable for pain upon palpation is less restrictive to most restrictive. It's going to be your semi-Fowler's or Fowler's position with a cervical collar or towel rolls only, pillows or blankets to fill voids, supine on the gurney, or a children's car seat. Methods used to achieve SMR that are allowable to neurological deficits Less restrictive to most restrictive is going to be your KED, your backboard with adequate padding, head immobilization, and straps. Stabilize the patient with the straps and head rolls or other similar devices. Once the head is secured, the second provider may release manual inline stabilization. Assess and record extremity neurostats and distal pulses post-procedure. If works, remove any immobilization devices and then reassess. Your exclusion criteria. The need for spinal motion restriction may be deferred for patients who demonstrate all of the following findings on an assessment. They are less than 55 years, absence of tenderness at the posterior midline of the spine, absence of focal neurological deficit, normal mentation, ability to communicate well independently through an interpreter, no evidence of intoxication or impairment due to drugs or alcohol, and no clinically apparent painful injury that might distract them from pain of a spinal injury. There's also a note where SMR should reduce rather than increase patient discomfort as well. Your key takeaways for spinal motion restriction, again, are the exclusion criteria, which is something that is new for us, that was just in effect April of last year. So if they're age less than 50 years old, absence of tenderness at the posterior midline of the spine, absence of neurological shock, normal mentation, ability to communicate well independently, no evidence of intoxication, or not clinically apparent painful distracting injury. And for our conclusion, just some final notes. Our on-scene goal time in a trauma activation is going to be 10 minutes. We want to control hemorrhage early, monitor vital signs closely, give fluid appropriately for patient's age and condition. If base contact is indicated, ensure it is through a trauma facility for the North Zone. Again, that is SF General. Always consider fentanyl for pain management, only if appropriate and no contraindications are noted. And when you're documenting your fentanyl and your PCR, be sure to provide vital signs and a pain scale before and after each administration. If that cannot be achieved, for example, AMR assumed care or they're transporting, then document so in your narrative. And Chief Powers will also be discussing a new trauma go kit that will be coming soon.